afternoon, everyone. My name is Jyoti Pathak. It's a true honor to present to you Iris OB Health. I'm the founder of this company, and we are trying to build a digital health platform to help women who are suffering from postpartum depression. I also have a day job of being a professor of informatics and psychiatry here at Weill Cornell Medicine. And I'm joined by my colleagues both in psychiatry, OB, and informatics as part of Iris. But before actually I introduce Iris to you, I wanted to share a very brief story about someone by the name Allison Goldstein, who was a fourth grade teacher in Virginia. Lovely woman, lovely husband, great marriage. But about 4 months after her son was born, she ended up taking her own life. Turns out that neither her husband, her family, or her care providers were aware that she was suffering from significant postpartum depression. Perhaps some of you could relate to a story like this, because this is very, very common in this country and certainly across the world. CDC statistics would suggest that about 1 in every 5 women in this country suffer from what is called as perinatal mood and anxiety disorders. And unfortunately, about 50% of these women remain undetected. And as a result, after post-pregnancy complications, postpartum-related depression is now the second leading cause of death. And some recent numbers from Mathematica research earlier in this year suggest that untreated PMADs cost upwards of $14 billion annually. While on one hand, there is some good news, there is much more public discourse about mental health in general, but certainly more about perinatal and postpartum depression. Earlier this year, the US Preventative Task Force actually provided Level B recommendation, which requires screening for postpartum depression at every prenatal visit. Perhaps more importantly, in March of 2019 as well, Sage Therapeutics, a company based in East Coast, got their very first drug approved called brexanolone for postpartum depression. So we certainly consider these as good news in trying to help patients who are suffering from this condition. However, at the same time, the current approaches, which require a patient to verbally check in with their provider at their office, use a paper-based form for reporting their mental health and behavioral health symptoms, and in many cases, download general-purpose apps from the iTunes store or the Google store to report their mood and symptoms is ineffective because it does not reduce stigma barriers. It certainly does not enable comprehensive screening. And at least in our own experience, seeing our own patients, it does not offer personalized and timely intervention. So that's where Iris OB Health comes in. We are trying to develop a platform that would facilitate early screening in a stigma-free environment, and that is very, very important. And subsequently allow patients to identify patients who are at a higher risk and provide timely intervention. The product that we are developing right now at Cornell comprises of 2 facets. So one is more geared towards clinicians, mental health providers, primary care providers, OB providers, and one is geared more towards the patients. So Iris for clinicians right now is focusing on using information from electronic medical records, both structured and unstructured data from electronic medical records to identify patients who are at a higher risk of postpartum depression, and based on their severity, suggest guideline-based interventions. So far, we have validated and developed this algorithm using information from Weill Cornell as well as across 7 different health systems in New York City. And earlier this year, we presented some of these results where the algorithm achieved a performance of 95% accuracy of identifying these patients. With respect to Iris for patients, what we are working right now is to develop a solution where patients can report their mood symptoms, their behavioral health symptoms, maybe their diet, maybe their sleeping activities as patient-reported outcomes. And we're working towards incorporating this information back into the medical record such that appropriate risk tiering could happen. And we are also working on additional functionalities like peer-to-peer networking as well as telemedicine. Our objective is that we want to introduce our patients to Iris as early as their first trimester, such that providers can facilitate continuous and proactive engagement not only during their pregnancy, but more importantly during the postpartum period when patients are most vulnerable. With respect to our business model, we are initially having discussions, again, with Cornell and New York Presbyterian here in New York, to essentially develop a SaaS-based model where we would do revenue sharing based on additional reimbursements as well as hospital savings. Just to give you some perspective here, right here in New York City, in our health system, there were upwards of 18,000 newborn that were delivered in 2018. And based on some estimates that we have done internally for remote monitoring as well as additional ambulatory care visits, we estimated about additional reimbursement of $30 million in 2018 just for one health system. We're still refining this model as we speak. In terms of our positioning with respect to some of our competitors, you could actually go to iTunes Store or Google Play to download multiple different apps, where we think our advantage is that we facilitate using information from electronic medical record to risk stratify, and more importantly, facilitate personalized engagement and treatment interventions for our patients. We were very honored and fortunate to be the winner of the Weill Cornell Biomedical Business Challenge earlier this year, which offered us a generous funding of about $75,000. And we're using that money right now to actually work on our MVP and also do a pilot study at Weill Cornell and New York Presbyterian with both patients and providers. In addition, we are trying to raise some seed funding in next year, as well as applying for NIH, SBR, and STTR grant funding. With that, thank you for giving the opportunity to present IRIS, and we are trying to nurture healthy motherhood. Thank you.
So I'll just start by saying I think what you're doing is amazing. The stats are incredible, and having 2 kids, I appreciate just in general knowing that this is out there and not as many people admit to it. So my question really is, for the product for the user, it's going to be like an app-based product that kind of takes them through a list of questions that maybe don't seem as offensive to them as they're going through it, and so they're more comfortable answering them just like on their own phone.
Right. So right now, our initial consideration is to use a validated screening instrument. It's called the Edinburgh Postnatal Depression Scale, which has been validated both US and as well as globally. So it provides a 10-question questionnaire, again, talking about your mood and symptoms and behavioral health-related issues. So that is our initial pilot phase that we want to do. And subsequently, we will probably venture into issues around fitness and diet and sleep. Yeah.
Okay, great.
I'll echo Noel's sentiments. I have a 2-year-old, so this is very important to me as well. And I actually suffered from postnatal depression, so I could have used a tool like this. My question is around how you coordinate with different doctors who may see the patient throughout her course of prenatal visits and then postnatal visits, because sometimes systems don't communicate with each other.
That's a great question. So our focus has been to facilitate as much as possible in-network referral. So when we are seeing your OB provider, and if our system flags someone as a higher risk, we would facilitate in-network referral for a mental health provider, a psychiatrist, or a therapist within the network. So that's been our model that we have been exploring so far, at least with New York Presbyterian Hospital, and there's a large health systems. I think the model will probably be a little bit different when we're working with smaller health systems who may not have a mental health system associated with their OB care. So that's something that we're still flushing out, to be quite honest.
Awesome idea here, and I have 3 little kids myself, and I'm sure my wife didn't communicate any of the issues she went through on this, but I'm really impressed with what you're trying to do here. Selling into hospitals is really hard. It's a long sales cycle. Talk to me a little bit about your strategy along the lines.
Again, a great question. Yeah. So far we have experience of N = 1, which is our own health system. And when we talk to our both OB practice and psychiatry practices, they see a real need, because a lot of these patients who do not get their care during both the pregnancy and the postpartum period end up coming back to the ED. So the hospitals see a real incentive in terms of how this could lead to not only better patient outcomes, but subsequent cost savings. So that's been our value proposition, but I confess, so far our discussions have been primarily with our own hospitals. Having said that, we are trying to do a small pilot study with University of North Carolina, and I used to work at Mayo Clinic before, so my former employer at Mayo Clinic, but those are very early stage discussions.
Yeah, I definitely concur that you're doing God's work here. That's great. Can you tell me can you tell me how the scientific validation you got for the screening method has been accepted by your target hospitals? Is it really something that they find very compelling, or is it more that this is a problem that they really feel and are trying many new things?
Right. Great question. I think as a provider, if you present, as you know, whenever we do outpatient OB visits, there's very limited amount of time. So adding another risk score to the probably 3 other risk scores that are there is not very effective. unless you can associate the risk score with certain types of interventions. It could be a psychotherapy intervention, it could be a pharmacological intervention, or it might be that these patients need more routine screening and follow-up. So I think that's the part where we can associate the risk profile with certain interventions. That's when the providers feel there is a lot of value add that they can do within, let's say, a 15-minute OB visit. And that's what we're trying to achieve, actually.
Great, thanks so much.
Thank you.